This episode is brought to you by Progressive.
Are you driving your car or doing the laundry right now? Podcasts go best when they're bundled with another activity, like Progressive home and auto policies. They're best when bundled too.
Having these two policies together makes insurance easier and could help you save. Customers who save by switching their home and car insurance to Progressive save over $775 on average.
Quote a home and car bundle today at Progressive.com.
Progressive Casualty Insurance Company and Affiliates. National average 12-month savings of $779 by new customers surveyed who saved with Progressive between June 2022 and May 2023. Potential savings will vary, not available in all states.
This episode is sponsored by One Welbeck. Hello everyone, I'm Nicole Goodman.
And I'm Lauren Mishkon, and welcome to Self-Care Club, where for the whole month of October, we're talking about the menopause.
World Menopause Day is held each year on October the 18th to raise awareness, break the stigma and share support available for improving health and well-being for women experiencing menopause. And that is exactly what we are planning on doing. We're interviewing some amazing doctors and asking them all the stuff that you might be too embarrassed to ask or even talk about.
Yup, we are really going there to dispel myths and ask all the questions that we hope are going to be helpful to women. After all, menopause is not optional.
It isn't, Lauren.
It isn't. It happens to 50% of the population. And by 2030, 1.2 billion women will be in or post-menopause.
Shifting levels of hormones, especially estrogen, during the transition into menopause can cause changes in a woman's body. Both the vagina and the vulva can be affected as well as the bowels.
Studies have shown that approximately 50% of postmenopausal women experience vaginal dryness, yet only 25% seek treatment. And women with incontinence issues will wait 6 years before they seek help.
Oh my God.
And only then will they mention it to their doctor if she is female, if she looks interested, and if they feel she's old enough.
Wow, that is a high number. So despite this high number of women experiencing problems, it is still a silent problem that many people feel embarrassed to talk to their partners, friends, and even healthcare professionals about. But today, that is exactly what we are here to do.
So we're welcoming not one, but two very special guests who we think may be the only people to have come on this show who are even more invested and interested in vaginas than me.
I mean, it's quite something. We've had to dig them out, haven't we? They are consultant doctors Elaine Palmer and Sarah Mills. Miss Elaine Palmer is a forward-thinking consultant obstetrician and gynaecologist who provides specialist vulval and advanced menopause care both in the private sector at One Welbeck and the NHS. Following completion of general gynecological and obstetric training, Miss Palmer undertook advanced specialist training in vulval disease, having developed this unique subspeciality interest early on in her training, where she saw that exceptional individualised management of vulval and vaginal disease could impact positively and empower women in an area of medicine that otherwise seemed to be overlooked or sat on.
Quite literally.
Miss Palmer became one of the only 17 UK gynecologists who completed advanced training in this field 10 years ago. That is exceptional, isn't it?
Yeah.
From a menopause perspective, after recognising the major overlap that this area of healthcare had with vulval vaginal disease, Miss Palmer took great interest in peri and post-reproductive health and the significant impact hormonal issues can have on a person's quality of life. Wow. She is an active member of the British Menopause Society, BMS, and then gained BMS Advanced Menopause and Specialist status. 2 years later, she gained BMS Principal Menopause Trainer status and trains those wishing to learn or specialise in menopause care, as well as running her own menopause clinics privately and in the NHS. She is a brilliant communicator and an empathetic care provider who is proud of her Welsh heritage, believing that caring and kindness should be at the forefront of all patient interactions.
Miss Sarah Mills is a consultant colorectal surgeon at One Welbeck Digestive Health, specialising in minimally invasive surgery for colorectal cancer, anal cancer and inflammatory bowel disease. She is an honorary senior lecturer in the Department of Surgery and Cancer at Imperial College London and the MTD lead for colorectal cancer and rapid access colorectal cancer pathways at Chelsea and Westminster Hospital. She has a specialist practice in interventional endoscopy and cutting-edge techniques for treating treating complex polyps and early rectal cancers. She sits on the Royal Marsden Partners Regional Cancer Alliance Group, which leads on developing strategies to improve cancer care in London. Having graduated from Oxford University Medical School, she undertook surgical training in Oxford, Melbourne and London. And prior to taking up a consultant post at Chelsea and Westminster Hospital, she was awarded her doctorate in 2005 for her work at St Mark's Hospital, London. Miss Mills also has an active interest in global health and regularly leads and teaches courses in low and middle income countries in Africa. These include a multidisciplinary course for theatre teams of surgeons, anaesthetists and nurses, focusing on using non-technical skills such as communication, leadership, situational awareness, decision-making and conflict resolution to improve patient safety and outcomes. Ladies, a huge welcome to Self-Care Club. Thank you so much for being here.
Thank you for having us.
Thank you for having us.
Before we get into the real nitty-gritty, I want to start with what is probably the biggest issue for everybody, which is embarrassment. There are so many women who I know and you have told me are suffering with all sorts of different things, but they just keep it to themselves. So what would you say about this big topic of I've got an issue with my downstairs and I can't talk about it because I'm so embarrassed?
This is a very common problem in our field of work, which, as you say, is downstairs and not something that people find very easy to talk about or to come and talk to a doctor about. And often people have had bad experiences of trying to talk to doctors before. Lots of women, I'm a colorectal surgeon, lots of women with problems with their bottom have had them since they had children and been dismissed before and told that that's just part and parcel of being pregnant and having children. They have to put up with things. So I think that's one thing that to get over. And then the other is nobody likes coming to clinic and having their bottom looked at by anybody. So, it's really about encouraging people to do that and education. And when they do come, making them feel comfortable to do it.
When should they come? If they're experiencing any type of discomfort or pain, should they always be coming to get that checked out?
Yeah, nobody should be putting up with an uncomfortable bottom, whether that be itching or soreness or bleeding or anything they're worried about. Obviously the main thing I worry about in my world is cancer. So anyone with any rectal bleeding, there's been a lot of publicity around this already, should be coming and getting it checked out.
Yeah.
We're picking up lots more cancer in people under 40 and 50 these days. Rates of bowel cancer have gone up a lot. We don't really understand why fully. So anybody with symptoms that persist should come.
And if you are a woman experiencing this stuff, would you be able to request a female doctor?
You can certainly request a female doctor. It's just not always possible in the NHS. In the private sector, there are female doctors around, but it's not the glamorous end of surgery. There's not very many of us in colorectal surgery, but there are definitely some.
Yeah.
I think you can always request a female doctor, but I don't think you should be worried about showing a gentleman your bottom or showing a gentleman your vulva or your vagina. I think it's something that we often feel that there'll be a link between you both, but actually lots of gentlemen are even more sensitive than perhaps women because they really will feel for you and the symptoms you're going through. Because often women will relate to ourselves, so we'll often think, oh, that's not too bad. So actually seeing a gentleman might be the best thing for you. And actually you can use any word you want to describe down there. And I think that's part of the problem with embarrassment. We often don't know what to describe we're feeling. We don't often talk about sex with somebody outside our relationship.
Yeah.
You might talk to your best friend. I imagine you two chat all the time about things like that, potentially. But perhaps people don't talk about it. But what do you call down there? We're calling it down there. We're saying your bottom, your vagina, your vulva. Most of us don't even know what our areas down there are called.
Yeah.
So I think it's just go in, you say what you feel. If you can take pictures, you can point to something brilliant. And there are lots of websites, NHS and private, that you can help yourself by even showing somebody on a picture, that's my problem. So just empowering yourself to go in and not be frightened. That's what we're there for. We talk about these things every day.
I think people forget that is that to them, it's a very embarrassing problem that they've got that they don't want to show someone or talk about. But to both of you, you are dealing with this and seeing this every single day. It's what you do.
This is our bread and butter.
Yeah.
And, the other thing to remind people is that these problems are so common.
Yeah.
They say that there are two types of people in the world, those that have hemorrhoids and those who are going to get hemorrhoids. They're that common.
Love it.
Amazing.
I think it's a bit the same with your vulva. If most of us have experienced some soreness down there, most of us will pop off to, one of the local chemists and pop something on there, or you just sit on it and hope it goes away. How many times have we all bought some cranberry juice to try and make things feel a bit more comfortable? Or you try your old wives' tales. We all experience problems. I just don't think we talk about them enough to know what they might be.
Well, we're going to talk about them today.
What are the most common things that you see in your clinics of women that are coming into perimenopause and menopause? What are the most common symptoms that they are complaining about?
So from my perspective, it's really individual with each patient. And I think that's the key. Your menopause is your own. Your perimenopause is your own. And you can't judge it with anybody else.
I want to put that on a T-shirt. My menopause is my own.
It is.
Please don't. Please don't put it on a T-shirt.
It's your own journey. And I think that's the key. And I think we often try to attribute menopause to simple symptoms. And if you go to your GP, quite often they'll try and fit you into a box to say where you are in your journey. And actually, everybody's journey is different. I think it's working out what things have changed in your life to affect your quality of life. If you look at our puberty, we were just talking about children just now. Everybody's puberty is different. Some of us get acne, some of us get mental health issues, some of us can't go out the house and we're having to sit with a hot water bottle. If you look at boys, their voice breaks at different stages. We're all different. It's the same with menopause. But I think the most common things I tend to see are anxiety as one of the biggest things, especially if you've had period problems before where you may have had anxiety during your cycles. I think shoulder tip pain's a big one that we miss a lot because it's subtle. We often just think it's because I've overworked that shoulder, been to the gym, brushed my hair.
I'm getting the hard stare from Nicole with my frozen shoulder issue.
She's had a frozen shoulder for months.
Foot pain, but then obviously there's night sweats, lack of sleep. But all of those things accumulate. And vulval issues actually tend to be one of the last things that come.
Are they?
Because you tend to get a dry vagina a little bit later on when your estrogen drops off.
Right.
But lots of ladies will get dry skin down below that makes sex uncomfortable. But again, we tend to just, put a bit of cream to treat thrush or other things down there. But we were just talking, bowels are a big thing.
Yeah.
Most of us notice our tummy's getting a bit bigger. We're getting that middle tummy that our men get. And we're not sure what to do. We change our diet, but also our diet and bowel habit changes. I think Sarah can tell you a bit more about that.
Yeah, so the commonest thing I see with women sort of around the menopause is them noticing a change in bowel habit. And that's usually towards constipation, but like Elaine says, everybody's different. It can be different for everyone. Sometimes with lots more bloating. And I think there's sort of an algorithm to work through on that front. There's, some tests that sometimes need to be done to exclude any serious colonic pathology, exclude cancers. But that's not the case for the majority of women. It's a functional change with the bowel related to the estrogen levels dropping off. And they might come and say, I've just noticed a change in my bowel habit, or they might come because their constipation has caused them to have something else, like some hemorrhoids or a fissure, something along those lines. So, and there's a lot that can be done for that sort of thing, dietary manipulation. I work with some really good nutritionalists who can help women in this field. And then, of course, if they end up with some painful, uncomfortable, itchy, sore sequelae around the bottom because of it, there are treatments. Those people don't have to sit on them, literally, for long periods of time.
Yeah. And would HRT help with that?
It does sometimes, but not for everybody.
Okay. I read something about, I don't know if this is true or not, that when you go through the menopause, your vulva actually shrinks, it changes in appearance, and so your urethra is coming forward more, which is why so many women experience UTIs, lots and lots of UTIs. Is that true?
It is. Things down there generally change. I think if we look at what happens in the menopause, initially it's like the second puberty. So your brain normally talks to your ovaries every month when you're not in the menopause, and it talks to them by whispering at your ovaries when you're young to produce an egg every month.
Yeah.
As you get a bit older, your brain has to shout more, and when you're getting into your 40s, it's screaming at them, and then you get to a point where it needs a hearing aid to know what's going on. Now, whilst it's screaming, sometimes you'll get fluctuations in estrogen. So sometimes you'll get loads of estrogen produced and you'll be on a roller coaster, but sometimes there's hardly any. And it's those fluctuations that change things. Now, the vulva tends to get involved once you're really low in estrogen. So your brain's screaming, the hearing aids are on, but your ovaries aren't hearing anymore. You've got low estrogen most of the time. And what tends to happen, a bit like you'll often see if you look at your granny, you look at somebody a bit older, they've often got thin lips. So if you look at their face, their lips have thinned out They're having to put lipstick on, but they're licking it off and it's getting stuck in the cracks and crevices. They've not got those plump lips that you used to have. Now, the mucosa of your genitals are exactly the same as your lips up here. So what tends to happen is everything down there gets drier. It loses its plumpness. It loses its vascularity, so the blood supply. And you tend to get dry. But especially at the back wall of the vagina, in what we call the cup. So it's called the vestibule, and it holds your vagina, where you have your babies from. It holds your where you wee from, all the important structures. That little area dries out significantly, especially around where you wee from, your urethra. Now, once that dries out, yes, it can come forward, yes, it can move backwards, but it's dry.
Right.
And it's literally like you'd have a dry mouth and you wee over it every day. And you can imagine you're going to feel like you've got a wee infection all the time. If it gets a bit cracked, because you might have tried a bit sex, because the area's where it is, you get sore.
Yeah.
But there's also a little tiny bit of tissue at the back wall of the vagina or the back wall of the vulva that dries out even more. And it's literally like your hand. So if you look at your hand, you've got this small bit of tissue.
Yeah.
So if you have a little peek at that area. Now, you know if you're a bit dry there, how uncomfortable that would feel as you move your fingers. Now, we've all got different textured skin already. But it's that little bit at the back wall of your vagina, just on the entrance, that most people have problems with sex with. Because that little bit dries out and it becomes very stretched. Yeah. And the minute you put anything over it or in that area, even a tampon, it cracks down the middle. But then you wee over it every day and it gets dry, and none of us put any cream on it. But if it was the corner of our mouth, we put a bit of lip salve or Vaseline on. So it's those things that we don't look after our vulva very well. We'll all wash it with a bit of soap. We'll, buy one, get one free from the supermarket. We'll put whatever we want on, something bubbly that smells good, because we're always worried about that. And actually, water even dries us out, plain water. Although water's a lot better than soap and shower gel, we all need a creamy moisturiser to wash with. And we most probably need to take a little tin of something greasy to just pop down there like you would on your lips. Those small things make the difference. But yeah, UTI symptoms are huge because of that drying out of that area. And the way we can treat that is with moisturisers. We can treat it with lubricants, but also we've got local estrogens that we can even use in cancer patients.
Are they a pessary?
They're like pessaries, there are creams, there are gels. Again, it's about individualisation.
Right.
You might just want to come and chat to us, chat to your GP about what's best for you. Are you okay popping a little tablet inside your vagina, or do you think that's something you wouldn't want to do?
Because there's a lot of confusion between women who are constantly treating themselves for thrush.
Very true.
Who don't have thrush, who are going through Canesten creams, and the problem's not resolving because they're not treating the right problem, right?
And most ladies won't get thrush when they're menopausal because they don't have the tissue that develops thrush. So actually it's a mistake thinking it's there, but you get itchy, dryness and soreness.
Yeah.
So of course we think it's thrush.
Yeah. Because that's what you would associate it with, because you haven't had this problem before, right?
Exactly.
Okay. Can I ask you about something else really
Ask
unpleasant?
anything.
I'm just going with these questions.
It's not unpleasant. It's actually, we're educating ourselves.
What I mean is, I feel like people don't want to talk about these things, and I feel a
always,
responsibility.
you always want to talk about these things.
I'm very open talking about it, but not everyone is. Vaginal discharge. Is there a change with perimenopause and menopause?
Again,
what's normal, what's not?
Everybody's different.
Okay.
So some people, when they're going through the fluctuations in estrogen, like we said, that roller coaster,
Yep.
they might be getting high levels of estrogen and producing a bit more discharge. So it might be a bit more creamy. There might be more of it. So you might think, wow,
Does it matter?
I'm really wet down there. It depends on how it's affecting your life.
Okay.
Right.
So some of us, we've never worn a panty liner in our life. We're dry most of the time. We don't have to think about it. There are others of us that have to wear a panty liner every day because we're always a bit moist. Whenever you get a change, most of us will notice it. Most of us will assume there's a problem. And most of us will think, oh, it's affecting my life a bit. The question is it? If it's white, it's clear, it's not smelly, it's not a problem.
Okay.
But dryness is an issue. So the question is, are you dry? If you're dry and you're scratchy and you're uncomfortable and you can't have sex, that's when we need to do something.
Right.
Okay.
So getting a bit more, maybe not a problem. But if you start to get sore because you're a bit damp down there all the time, perhaps we need to think about that. Some people get eczema from being a bit more damp.
Okay. Hadn't even considered that.
But again, it depends on what you're used to. And I think that's half the problem. We don't know what normal is, but your normal is whatever's normal for you.
Right.
I think part of the issue, and I'm speaking as a generic woman here, is there's such a lack of education about all of these issues for women going through the menopause, isn't there? Why is that? Why is this not talked about more, do you think?
Well, I think as women, we have to take some responsibility for the fact that we're not very good at talking about it and coming forward and saying, I've got this problem and it's really uncomfortable and it's affecting my life and I want to do something about it. We're not very good at coming forward and doing that. I think there's not a lot of public health sort of messaging and education out there about stuff to normalise it and make people realise that this is common stuff and we should be talking about it. I think, you know, there are lots of people addressing that now. But, you know, I think we have to take some responsibility for it ourselves and talk about it and make it okay for women to talk about things.
Yeah,
and give them the language and the vocabulary to do that.
I also think education, I think we always talk about education, but I think even when you're younger, we don't really talk about puberty that much, even in school, do we? So we're hardly going to talk about the menopause. I mean, I don't think, you know, most of us remember a little bit about doing plant biology in high school where you learn about plants and, you know, their stem and their petals and how they reproduce. But did we really talk about how your ovaries work or even how boys' bits work? I don't think we have the basic knowledge on top of the fact that we just don't talk about it.
And I think another problem is that doctors don't talk about it or aren't always very well educated about it either. I mean, Elaine and I were doing a podcast a few months ago and with a endocrinologist, and she was talking about how she had no teaching at medical school on the menopause.
Yeah.
I was quite shocked by that.
I'm not, because I've heard it already.
And also the doctor, when we saw you guys at a panel on International Women's Day and you were talking so openly
It was in that panel,
about all it, and she absolutely, I was gobsmacked. A hormone doctor basically doesn't get taught about the menopause.
2 hours of it or something in her whole 7 years of learning to be a doctor.
And yet she'd had quite a lot of education on hormone supplement for men.
Yes,
of course.
Yes.
Of course.
It's amazing that we all had the same takeaway from that night. I mean, there were many takeaways, and I was totally educated on how much we as women still don't know and still aren't aware of. And I think that I absolutely agree with what both of you are saying. I don't talk to my friends about things like this ever. And if I did have something wrong going on down there, I would really struggle to go to the doctor with it. I won't now.
Would you really?
Yeah.
Would you tell me? Because you know that I would be the only person who would be totally cool about it.
I don't know. I would after today.
If it does happen, then just tell me.
Well, now I know who to go to. Now I don't need you.
Can I make a shameless plug for a brilliant event that I went to last year?
Yes, please.
A friend of mine who's a colorectal surgeon down in Cardiff organised, called the Every Woman Festival. I don't know if you've heard of it.
No.
It was unbelievably popular. It was held on a beautiful sunny weekend in Cardiff, and about 2,000 women turned up. There were men there as well, but it was to talk about women's issues, sort of gynaecological, urological, general health, mental health. And it was such an amazing, empowering environment of women sort of coming together and talking about it and normalising things. And there were lots of workshops and talks and lectures and then just really simple stuff like potato printing diagrams of your genitals to educate you what is what and how to have the language to talk about where the problem is.
Love that. I really like that.
So helpful.
Something so common, and it's like such a joke around middle-aged women. Oh, I sneezed and a little bit of wee came out. This seems to be talked about all the time, but only in a kind of joking.
And it's not
isn't
always
it
a little
awful?
bit.
Oh, isn't this
Especially
terrible?
on a trampoline.
Oh, forget it. Those days are long gone.
Skipping, but
I wouldn't go on a trampoline now because of that.
why does that happen? Can we do anything about it?
Can we?
What's the reason for it?
I think Sarah and I most probably, I think this is our area in general. Leaky bits and bobs, shall we call
Leaky bits
them?
and bobs.
You do the leaky bit at the front and I'll do the
Leaky bit at the front
back.
and you'll do the bobs.
Right.
And I think this is the key. I just, again, don't think we talk about it. I don't think we realise most of us will suffer from urinary incontinence. So a little bit of wee leaking out at some point.
Is this during the perimenopause?
It can be at any time in our
Okay.
lives, but we tend to notice it more in the perimenopause and the menopause. So,
Why? What's going on?
And immediately postpartum.
And immediately after
yes.
you've had a baby, or even whilst you're carrying a baby, you tend to wee a little bit more and you don't know what's going on. Have I broken my waters? Am I just weeing? Am I just sweaty down there? I mean, it's been such a hot couple of months recently. I mean, did you wee yourself? Or have you just sweat? I mean, what's going on down there?
She's climbed into my brain.
And I mean, I'm surrounded by lovely ladies that have had babies already, but I mean, you can suffer whether you've not had a baby as well. But your pelvic floor and your pelvis in general, we're not the best designed. I mean, I think we're marvellous creatures as women. We're designed to have babies. Our vaginas and vulvas are amazing. We do loads down there. But basically, we've got a big open bucket down the bottom end of our bits. And there's loads of pressure on top of it. We've got our tummy, we've got gas, we've got wind, we've got a uterus. We all stand on our feet. We're most probably not meant to. You know, we're either meant to be crawling around on hands and feet or swimming, I imagine. But what we do is our pelvic floor is like a sling underneath our bits. And what happens in the menopause is your estrogen drops. Your sling gets worse. It's like scaffolding that's got a bit saggy. And whenever your scaffolding's got a bit saggy, you leak a bit. So you cough, and instead of your pelvic floor holding everything where it's meant to be, it drops a bit and you leak a bit. On top of that, you're a bit drier. So, and your urethra might be, like we said, a bit cracked and not quite as good as it used to be. And you get a leak. And some of us get twitchy bladders because of our menopause.
What's that?
So often they call it lock and key syndrome. So you need a wee, or you're not quite sure, but you put your key in the lock in the door, and it automatically triggers your bladder to know, oh, I'm near the toilet, just by knowing it. And your brain makes your bladder twitch and you wee yourself.
I don't
It's not because of coughing and sneezing. It's just you've got an overactive bladder. Much more common in the menopause. Especially
God,
if you keep
Nicole,
getting
God
these
help you.
symptoms.
It's definitely going to be a Nicole
But
problem.
the classic dancing with your kids, trampolining, is just because that tube and those little muscles that hold everything in, they're a bit more lax than before. And we all talk and joke about doing your pelvic floor exercises whilst you're doing the dishes.
Yeah.
Most of us have a dishwasher
Whoever
these
did pelvic
days.
floor exercises.
And whoever did them. But they're so important. And we should be doing them from puberty onwards. We shouldn't just wait for the problem. We should be taking our pelvic floor to the gym from childhood onwards. If we take our rest of our body supposedly to the gym, I'm not exactly the best person to advocate for that. But,
Me neither, Elaine.
But actually, if you can squeeze those muscles, keep them ready, when you go to the menopause, how much better are you going to be?
We've got that machine at home. We
Well,
did a show on it.
What happens if you're in perimenopause and your pelvic floor isn't great? What can you do then?
So best thing to do quite often is have a little look on the web for some pelvic floor exercises and start them off. Your GP will be able to send you to community pelvic floor clinics.
Oh, that sounds like a fun night
You
out.
can come, exactly. And there's wonderful physiotherapists that will teach you what to do.
BYOV.
Yeah.
There's also a really good app called the Squeezy
Squeezy
app,
app.
which is an NHS initiative. With some people are really app driven these days and really motivated by an app telling them, do your pelvic floor exercises.
And it teaches you what to do.
We've got the
They should
Intima
have it
pelvic...
on the Apple Watch.
I bet
you know
they do. I bet they
every now
do.
and then they say like stand up or breathe. They should have
Homework for you
squeeze.
ladies, please find
We
the
got
app.
given this little machine by Intima, not machine, like a little pelvic floor trainer that you kind of insert and do the pelvic floor. It was during lockdown. Do you remember?
I do.
And we did a whole episode on it, and I was using it, and then this guy came up to my bedroom to check the internet.
Yeah. And she had it in.
I had it in. I was dressed, but I had it in, and he was like, "How's your broadband speed?" I was like, "Fine, fine. Please leave my bedroom."
I think that's an important message to get across, though, is that these are just muscles. You know, if you look at your arms and go, "Oh, they get a bit flabby," you take yourself to the gym and do some exercise.
But we don't do that. We just expect it's going to be fine. And most of us cough and sneeze, and then we think, I hope it gets better.
Okay, that's the bits. What happens with the bobs?
So the bobs, it's the same sort of story. It's all part of the pelvic floor thing. You've got the urinary openings at the front, you've got the vagina in the middle, and you've got the bottom at the back. And your bottom, your anal canal, has a sphincter complex around it. And like all your other muscles in menopause, it gets a little bit weak and a little bit saggy. The sort of compounding factor for women is that often those muscles have sustained some damage during childbirth.
Right.
And not just during childbirth, but also during pregnancy. I mean, carrying a big baby around on your pelvic floor can cause some damage as well. And whilst you're young and your muscles are a bit better and your tone is good, you can accommodate for that. But what often women find in their sort of later 50s, 60s and 70s is that an injury they might have had during childbirth suddenly declares itself. And often there's a precipitating factor, like, they go away, they get some very nasty traveller's diarrhea, and suddenly it seems to tip them over into being a bit fecally incontinent and having a bit of leakage and thinking, is this what it's going to be like now? Am I going to have to put up with this? And the answer is no. There's lots of things that can be done about it. But, you do have to come forward and have a chat to someone about it.
Which could be really, really mortifying. I can
Sure.
really see how hard that would
now,
be.
is it? Because now we've been given now we know what to say, and that it doesn't need to be embarrassing, and that it's really, really common.
Really
right?
common.
Don't suffer on your own. And also don't use the wrong sanitary products. Don't use the wrong incontinence products. Don't go put the ones on for periods when you've got leaky bladder. Put the ones on for leaky bladder so you don't get sore bits. Because it's like you get nappy rash again with bum and vaginal juices. And you get sore bits on top of everything and you end up in a pickle.
And the cracked lips in winter is a brilliant analogy. I mean, Elaine's completely right. I mean, that's one I use all the time to tell people, if you've got sore skin around your bottom because you've got a bit of leakage or because you've got some hemorrhoids that are exacerbating your leakage, or you've got a little fissure that oozes a little bit, people get very sore and excoriated around their bottom. And sort of saying, think about it like chapped lips in winter. Every time you go to the loo, every time you have a wee, just put some barrier cream on it, and there's a whole range of different barrier creams and sprays, and it's just a matter of finding the one that works for you that you're going to use.
We'll try and give you girls the healthy bottom and skin of your bits little guide so you can pop it up for you.
Oh, we can put that in our show notes.
So that people have got something at their fingertips. Because I think it's always nice to have something that means you don't have to go to the doctor. But we are, don't suffer. Don't suffer.
So besides doing your pelvic floor, is there a point where, I know some people I know have had like a stitch put in to stop their
There's loads of different
incontinence?
things. So as Sarah's saying, we usually start with the simple things because actually if you've never been to the gym down there and you haven't got the muscles and we haven't helped it, even any surgery or anything we do afterwards, it's not going to be as good. It'd be like you going in for a tummy operation and you having never been to the gym and expecting you to get yourself a six-pack afterwards. You've got to do that basic work first. Diet always helps.
Pelvic floor physiotherapists.
Oh, yeah, they're brilliant.
They're amazing. And they've got so many different techniques.
My friend goes to one. It's changed her life.
That's so good.
But then there are specialists, most probably slightly outside of our range. I mean, for bottoms, it would be you. For me, there are doctors called gynaecologists or urologists, and they will do those special areas. But you've got to go to your GP and just tell them your symptoms. Don't be frightened. And if you don't know how to describe it, use your own words. Your own words are the best.
Okay.
If you don't know what something's called, call it what you think it is or point to it.
Okay.
Be empowered to just use whatever you think.
I love
Some
that.
of your doctors, nurses may not even know what you're talking about if you use a medical word. So just talk with whatever you normally use.
Okay.
And if you feel like you're being brushed off,
Ask again.
Push on, and if it's really impacting on your life, then
be
insist on
heard.
having something done.
Don't be afraid to go back. Ask for a second opinion if you're not happy.
Okay.
We'd always want that, wouldn't we?
Definitely.
Can we talk about post-childbirth? So women who may have given birth, 20 years, 25 years previously and now find themselves in perimenopause and menopause. Are there issues from childbirth that can then affect you much later on?
So, the commonest thing that I see is women who've had undiagnosed sphincter injuries.
Right. So they've had like
and
a
so women
4th-degree
in
tear.
their 70s now might have had any sort of tear, second degree, third degree, 4th degree tear, or just an episiotomy, or there was a lot more and a lot less caesarean section sort of for women who were 70. So some women had very significant sort of obstetric injuries and don't know, it's not been well documented, it's been lost in their notes or in the history of time. And so I think it's important if women come forward in the sort of 50s, 60s, 70s saying I've got fecal incontinence, you start from scratch. They need an ultrasound to look at their sphincters, they need some erectophysiology testing to see what the muscles work like. Sometimes we do a particularly weird MRI scan. It's always done by a female radiographer where you get some, and I always warn women about this, you get some paste injected into your bottom and then you're asked to push it out in an MRI scanner.
Oh my gosh,
which sounds gruesome.
That sounds awful.
But it gives us a huge amount of information about the whole sling of your pelvic floor, front to back.
Yes.
It's an amazing test. But I think, again, because we don't talk about enough about these things, we all have a poo. I think lots of our partners think we never poo, we never break wind.
To be fair, being asked to do that in a radiology department is reasonably challenging.
It's challenging, but do you know what? It's such an important test.
My 11-year-old did say to my older sons the other day, well, obviously mum doesn't poo because she doesn't have a bottom because women don't have them. And I thought, okay, I probably need to address this before he gets a girlfriend.
That's a whole other discussion, talking to children about language and terminology.
Yeah.
Oh dear. Oh dear. Does estrogen and HRT in general, does it help with a lot of these issues?
Yeah, it does. It does. And I think we shouldn't be so frightened about estrogen. We've had more estrogen in the whole of our lives than you'll ever get in HRT. Every month you produce more estrogen than I'll ever give you in an HRT tablet. It generally will improve things because it will plump your skin back up.
Mm-hmm.
We know that. So if you look at lots of ladies on HRT, we definitely don't have quite so many wrinkles. Lips are more plump, bits are more plump. It gives you your muscle aches and joint pains and gets rid of them. But it also will help your urethra, your sling. It will help, but it's got to be used in conjunction with most probably a bit of exercise, a bit of dietary advice. And you're never going to be 21 again. We know that. We've aged. That's part of the aging process.
Yep.
But estrogen does help. And it's always going to be your choice whether you choose to take some estrogen or whether you want to take over-the-counter or natural substances or do nothing, because it's going to be your journey in menopause. But ultimately, you've had two little endocrine organs, your ovaries, and they've died off.
Yeah.
And any other endocrine organ in the body, your endocrinologist would replace those hormones. The difficulty is we're outliving our organs.
Yes.
And we didn't used to do that.
Yeah.
You know, and if you look back to medical history, this is why they used to look at why women became calamitous in Victorian ages once they went through the menopause. This is why they look for things to make their women feel better. This is why they made them sit on mustard baths to try and bring back the blood flow down there, to try and bring their women back. If you look at all the old adverts back in the day, the medical science goes back. And menopause has been around for a long time. It's just more of us are going through it because we're living longer.
Yeah.
We expect to live a long time, and I hope we do. But we're living with a broken endocrine organ, and I think the stigma of trying to do things naturally is the wrong word. There's no such thing as natural. It's about keeping yourself healthy and happy.
Yeah.
And some ladies that have had breast cancer 3 or 4 times, they may want to go on estrogen. That's fine as long as you've had the chat and you know about it. And it's just risks and benefits.
Yeah.
Some of us don't need estrogen. Some of us do. But if tomorrow you had a problem with another endocrine organ, I can guarantee you won't even be asked if you want it. You'll be told to take something.
Yes.
And I think that's something we've got to remember.
I'm telling you, I would save my patches, because I'm on the patches, from a burning building. That is the first thing that's coming with me, because I don't cope without it.
Yeah, and some people are fine with it and some people aren't. And you can speak to lots of ladies, speak to your mums. My mum says that her menopause wasn't a problem.
So no, my
but
mum's
she
wasn't
did
either.
have some fluctuations. You look at other people and they can't survive their life. You know, you can't get up in the morning. You're so depressed. You're so anxious.
But it's the same as puberty. Some people sail through puberty. Some people have some minor bumps, and some people have like the worst couple of years
and I
ever.
think don't judge your friends. Don't judge yourself. Just think about how is this affecting me and can I be myself?
Yeah.
I was listening to a podcast the other day about the menopause. The interviewer was a man talking to a woman, and she said to him, listen, let me put it to you like this. It is the equivalent of every single man reaching 51 and their balls shriveling up, dying and falling off. Would any man of 51 put up with that? Because that's what's happening to every single woman. And he was like, no, that sounds absolutely awful. And she said, well, yeah, that's why women need estrogen and HRT, because we don't want that happening to us any more than you guys want that happening to you. And I thought, yeah, like we are kind of expected to suffer, and they have no idea.
We're not anymore, thank God. Do you think enough women are aware of HRT and the benefits that it brings nowadays? Do you think the education is getting through to most women?
I think education at the moment, I don't know if Sarah agrees, it's really difficult to know where to get your education from. There's quite a lot out there, and there's really good stuff, and there's a lot of hype.
Okay.
And there's a lot of individual, this worked for me, so it'll work for you.
Yeah.
And I don't think it will. I think the key is what we've got to remember is I wouldn't have my job the way I would. I wouldn't have so many different types of HRT and so many options out there if there's one drug that worked for everybody.
Yeah.
And just because it worked for your friend doesn't mean it's going to work for you. So I think the key is that use websites like the British Menopause Society, Women's Health Concern. They are robust websites. Once you've had a read through those, they've got great fact sheets. They're in different languages. You can get them translated, download them on your phone, print them off. There's podcasts, there's websites. They talk about breast cancer and HRT. What's my individual risk? When you listen to a breast surgeon and an oncologist chatting about it, really puts it into perspective.
Yeah.
Especially, for instance, that, you know, we all worry about breast cancer. But actually, if you're overweight, you've most probably got so much more risk than you taking some HRT.
Wow.
What about taking a glass of wine every night? That's actually more risky than you swallowing your HRT tablet or sticking your patch on.
Yeah.
So actually, taking it from your burning building might not be a bad idea.
Oh, it's coming.
You know, take
coming.
it over. You take your patch over your wine. You know, it's safer.
100%.
But I think those are the key things: is go to those websites first, and then listen to other women's chat about what they use after. So you're already a bit empowered to realise you might not be the same as that person. You know, every one of us here will suffer different symptoms or may not suffer at all.
Yeah.
And therefore, there's a different drug for each of us. I think that's the key at the moment. There's been a lot of hype over what's the best. You know, stick a patch on, it's much safer than oral. But actually, oral's really safe as long as it's in the right place. Some people don't absorb patches or gel. Now, if you only think that's the only thing you can give and it becomes the sexiest thing on the market, our little tablets disappear. What about those patients that can't absorb via the skin? The same with those that have got Crohn's or other issues. They can't absorb a tablet. So I think the key is start by thinking that I am an individual person. You are in every other way. You know, look at sanitary projects. Do we all buy the same pad? Same tampon? No, we don't. Do we wear period pants? We're totally different.
Yeah.
Same with the menopause.
I love it. Thank you. Thank you so much.
I think the only other thing Sarah and I were very keen to chat about today is that we wanted to say to people is take a look down there. Be aware of your bowel habits.
Oh, yes, you said this at the panel. I thought this was great.
We keep banging on about it.
Bang now.
Come on.
It's not an easy area
It's not
to
an
look
easier
at.
to look at.
And so if you can't look at it very well yourself, you can take a picture or get someone else to look at it.
Who?
Well, one of us. Or people
What
like us.
person? Apparently, I don't have a bottom. No one can take a picture of it.
I'm not looking at it. I'm just telling you.
Nicole, do you mind?
But we really want people to realise that there are lots of issues down there, but we don't want them to miss cancer. We don't want to miss pre-cancer. So if you've got skin changes on your skin of your vulva, go see your doctor. Get to know what you look like now. You know, if you're watching this and you're 16, have a look down there. Find out what you look like now. Have a look down there every couple of years. Have a look every couple of months. Get used to it. Be proud. We should be doing breast checks every month, shouldn't we? Or every couple of months. Do the same with your bits.
And the same around your bottom, you know. Women are probably a bit more aware of what's going on with their vulva and vagina. They forget to look a little bit further round and think about their bottom. So one really important sort of public health message that Elaine and I like to get on our soapbox and bang on about because of the service we've set up is about anal cancer. And it's really important for perimenopausal, post-menopausal women because these are the people who are getting it. And there's a perception, even amongst medical professionals, that it's people with HIV or gay men who have sex with men, are the people who get anal cancer. And certainly they're a very high-risk group, but they do not account for most of the people internationally who get anal cancer, and that is postmenopausal women.
Why is that?
So if you have had any changes on your smear, you're 30 times more likely to get anal cancer.
Gosh.
And people don't know that.
I
and
did
this has
not
come out
know
of
that.
research that we and other units have done. And there's a problem because there's a time lag. So women who are menopausal have not had a smear for a very long time. Often they've forgotten about all of that. They have a vague recollection they might have had some changes. They might have had some treatment, some colposcopy for changes. But they've forgotten about their bottom. And so there's a big increase in women who are getting anal cancer. They're getting it at a much later stage disease, so they're much more likely to die of it.
Oh, my God.
Wow.
So nearly half of women who get anal cancer get stage 3 and 4 disease. Your chance of surviving that, 50 to 60%. If you get stage 1 disease, 90% chance you're going to survive it.
So we're really keen on people who've ever had a smear change or have got a vulva, a vagina, bottom, even our men.
Or our trans patients.
Or our trans patients. We want them to remember that human papillomavirus is in all of us. We've all got it. It's not just because you've had sex, it's just there. We just want people to be aware of their genitals, of their bowel habit, so that we don't forget. Because Sarah and I are tackling a disease that we can keep at bay, and we're tackling an area that people don't talk about.
Yes.
And in the perimenopause is when we're seeing people. And we just find it quite scary that everybody thinks you have to be having bottom sex to get this. And you
Not
don't.
true.
It's not true. We all wipe front to back, or we hope they do.
And also, you know, the perineum's everything's so close together. It's
Yeah. All
basically all
next
one
door
reservoir.
neighbours.
If you've had HPV, which is what causes cervical cancer and anal cancer, on your cervix, your vulva, your vagina, it's around your bottom and in your anal canal as well.
And we forget their neighbours. So we want us, like us today, and we're all neighbours and friends, we want you to remember the neighbours down there. So
Okay.
that through your menopause especially, you keep an eye on things.
And it would
if
be a
this-
change to the skin that you would be noticing. What would be the first sign?
So you might notice some of the things that you get with other stuff, with itching, dryness, bit of bleeding, something a bit sore, ulcerated down there. But what happens before you get anal cancer is your skin goes through changes that are caused by sort of chronic HPV infection. So there are precancerous lesions, and we now know that we can treat those. They can be lasered off, And that very significantly reduces your chance of ever getting an anal cancer. And if we know you're somebody who has that problem, we put you into surveillance. And the problem is that the cervical screening program is amazing.
Yeah.
It is reducing very dramatically women getting cervical cancer. But that same HPV that would have given you cervical cancer that has now been picked up and treated when you were younger is going to give you anal cancer further down the line. And we've not had national or international screening guidelines. They're only just starting to come through now.
Okay.
So yeah, we just want everybody to keep an eye. So if you have got a dry bits or you've got sore bum and it doesn't go away with the treatments we've mentioned and you've been to your doctor, go back and say to them, I've heard about this HPV thing. Have a little read on some of the websites.
I once had something on my cervical
smear. You know, I've listened to the podcast today, come and see us. Because I think the menopause is so important, but we also don't want people to forget the other bits.
Yeah,
we want you
absolutely.
to live your life and be happy through your menopause and then live till the day, hopefully, you pass away fast asleep after a glass of wine, not with anything else. You know, so thank you, ladies, for letting us talk about our favourite topic on top of everything else.
That was
wow.
That was great.
I'm
to
blown
hear.
away by that. Thank you for educating us.
Yeah. Thank you for listening to us.
Well, thank you for being here. We know how busy you are, both of you. So we really appreciate your time.
Pleasure.
Well, thank you for talking to women about women's issues. We
So important.
We love you. So well done.
And for people that want to be in touch with you and perhaps make appointments with you, how can they get hold of you?
We're very easy to find online.
We are. We are online. If you look at either the NHS side of things, where we both work at Chelsea
Westminster in the NHS, and the service, the anal cancer service we're talking about, is called CANS, the Chelsea Anogenital Neoplasia Service, on the Chelsea Westminster website.
And we've got a menopause service at Chelsea and Westminster and a vulval service, which we're quite rare about. And we both do the same thing privately. We
have the same service.
We have the same service, and our ethics doesn't change. We treat pretty much everybody the same.
Great.
We're going to put all of that in our show notes.
Yeah.
So if you're listening to this and you are interested and you want to hear more and you want to find these ladies, just scroll down and all of their links will be below in the show notes. Thank you again for being here.
Thank you very much
for having us.
Hi, I'm Grace, host of Red Rum True Crime podcast. These cases focus on the true victims of crime. Why not jump in at episode 114, the tragic murder of Jasmine and Aaliyah? The main suspect in this case gave an extremely bizarre interview to a number of press reporters whilst he was drunk and reportedly high. He speaks about an awful lot on camera and has this completely inappropriate laughing and chuckling response when talking about the case. He may even have thought he was going to get away with the double murder he'd been accused of, but what he didn't know was that 2 undercover officers were on their way to catch him out, and he easily and willingly took the bait. You can find us wherever you get your podcasts. Just search Red Rum True Crime. That's Red Rum, murder backwards, REDRUM True Crime.